Good morning, ladies and gentlemen. We are about to start the Young Physicians Forum of the Ceylon College of Physicians now. In the absence of our President, Dr. Dumindra Munidas, I'll be presiding the event. I'm Upal Dissanayake, President-elect for the year 2024. Our first lecture is by Dr. Hirantha Hettige, Senior Registrar in Neurology, National Hospital of Sri Lanka. He'll be speaking on stroke heat syndrome. Now, starting from now until 12:15, the last 5 minutes will be for the question and answer time. So we invite Dr. Hettige to present his lecture and then confine himself for 25 minutes. Thank you.
Thank you very much, sir, for your kind introduction. So today my topic is stroke heart syndrome. So since starting our medical career, we used to learn from our patients. So till we try to learn from our patients, yes, we will improve ourselves. So I would like to introduce few clinical phenotypes of patients which I have seen during my training period, where one patient present with 38-year-old patient present with right side to the cerebral artery infarction. Post-stroke day 1, patient developed central chest pain and ECG evidence of inferior STEMI. The second patient, a 56-year-old female present with right side MC infarction. Admission, the ECG was in sinus rhythm, but on the post-stroke day 2, patient developed ECG, developed atrial fibrillation evidenced by the ECG. The third patient, who's a 67-year-old patient with multiple comorbidities, we took over the patient for rehabilitation, and the post-stroke, following the rehabilitation admission, the patient has developed acute onset shortness of breath, which ultimately turned out to be acute heart failure. So, understanding that these patients on the background of stroke develop cardiac problems, I was thinking whether there's a relationship, and there are few questions created in my mind which I try to find answers. Of course, we know that the stroke and cardiac events have common risk factors, but does the stroke itself cause cardiac events was my question. And the other thing is the diagnostic and therapeutic challenges that can occur concurrent with the cardiac involvement in stroke patients, and is there any early prediction of cardiac outcomes in our stroke patients? So I tried to do some literature survey where I found that the World Stroke Organization has recently in 2020s has made a task force where the upcoming field of neurocardiology, where there's a connection between cardiac need of physicians to have collaboration with the cardiologists managing patients who have specific brain issues as well as cardiac issues, taking the patient as whole, and this is something evolving area. Then I tried to see whether there any, in the history, were there any the connection between heart versus brain, where I found this Aristotle, where he always tried to discuss that heart is the main thing affected by emotions, and the connection of all sense organs and muscles via blood vessels is mainly by the heart, not from the brain. So these arguments are there from the beginning. And then I tried to correlate my clinical problems into two categories, where heart causes the brain problems and brain causing the heart problems. So in the day-to-day clinical practice, we can usually actually engage in these sort of patients. We have patients following cardiac arrest, where there's hypoxic ischemic encephalopathy, cardiogenic stroke, cardiac surgery procedures, which result in neurological injuries, cardiogenic syncope, and also from the brain-heart side, whether the cardiac outcomes following stroke is one of the evolving area, and reflex syncope and central nervous system play a role in hypertension. So during my literature survey, I could found that a large study where stroke and heart correlation tried to figure out where they were able to find that the initial stroke risk is there following the first and second month of the myocardial infarction, and the significant increase of myocardial infarction and sudden unexpected cardiac deaths following the initial phase of ischemic stroke. Then interesting study is there where following the stroke, the cardiac outcomes where absolute deaths were initially, the initial week, it's mainly the neurogenic causes. But with time, you can see that initially it's the neurogenic causes which are in the black, but with causes has been predominating compared to the initial week of neurologic causes, where the correlation of stroke relating to the heart damage is very important in future studies. And another large population-based study which was published in Neurology, the American Academy of Neurology, has found that ischemic stroke is associated with increased risk of major adverse cardiovascular events. So, ladies and gentlemen, with given platform, I would like to outline my main topics in this lecture, where I would like to define the stroke heart syndrome, and I would like to identify the stroke-induced heart disease, the pathophysiology, and present to you, and then the clinical phenotypes of stroke heart syndrome and the stroke heart syndrome in Sri Lankan clinical practice, which is very important, where with the given resources, how we can address this problem. So the definition, the stroke heart syndrome is new evidence of cardiac alterations or documented worsening of the premorbid cardiac function after ischemic stroke. So is there a time duration? Yes. So following the stroke, the cardiac outcomes peaks within the first 72 hours, and it occurs in the index event next 30 days are considered as stroke heart syndrome. Then you might think that then what will happen to the other cardiac events which can occur after 30 days? Yes, there's emerging area that long-term consequences of initial brain injury can result cardiac injury, which is evolving area in stroke heart syndrome. So considering the risk factors, there are general risk factors. Risk factors confine your heart, and risk factors confine your brain. So the general risk factors, the age and cardiovascular risk factors, which is common to your heart and brain. But there are cardio-specific risk factors like persistent coronary artery disease and structural heart diseases, and the brain-related risk factors like the stroke severity, how severe is the stroke, the size of the stroke, and involvement of the central autonomic networks. I highlight that word, involvement of the central autonomic networks, which is very important in the pathophysiological mechanism, understand the pathophysiology of stroke heart syndrome. So, few words about central autonomic networks, where usually our heart, it is innervated by the sympathetic as well as the parasympathetic system, where in the normal physiological state, the physiology, the parasympathetic drive is more compared to the sympathetic. And it is very important in regulation of the cardiac rhythm, blood pressure variation, as well as sleep-related cardiac physiology. So, stroke-induced structural and functional alterations can damage this cardiac autonomic network, which is one of the main points in pathophysiology of stroke heart syndrome. So evidence from the meta-analysis from the functional MRI studies showed that there are specific areas in the brain which is in the central autonomic networks, mainly the insular cortex, which the blood supply is mainly from the middle cerebral artery, and a lot of data is there that following a stroke, involvement of the insular cortex can cause major adverse cardiovascular risk. And also the anterior cingulate cortex and the posterior cingulate cortex, amygdala, hippocampus, and the prefrontal cortex, also the parts of the central autonomic nerve, which is involved in this pathophysiology. And also, which still it's not there, the thalamus and also the nucleus of the vagus nerve, the brain stem, also have connection with the central autonomic network. So the lesion network mapping in the central autonomic network system has showed that sleep disordered breathing during the early post-stroke phase mainly happen due to insula and brainstem infarctions. And also, because of this, it can cause major cardiac autonomic, it can affect cardiac autonomic dynamics, resulting stroke heart syndrome. So since I mentioned about the central autonomic network, the connection of central autonomic network with the brain is very important. We have the efferent and the efferent fibers, which always the brain has the connection with the heart. And also the hormones also there for the connection as well. So the vagus nerve as well as the sympathetic fibers have always connected with the heart. So sometimes you think that whether the things come from your heart or your brain or from your mind. So that's clearly explained from the central autonomic networks where there's clear connection. So once describing that, the brain-heart axis is very important, where it's explained to it's important to explain the neurogenic cardiac injury. So neurogenic cardiac injury is not restricted to ischemic stroke. This concept can be applied to other acute brain disorders which can cause cardiac damage, such as seizures, and also traumatic brain injury, CNS infections, and also intracranial hemorrhages as well. So during the experimenting stroke-induced cardiac injury, there has been a lot of animal studies where one group of people has tried to occlude the left middle cerebral artery and in the mice and see the cardiac outcomes, where they have found that there has been left ventricular ejection fraction reduction as well as electrocardiographic features which suggestive of involvement of the cardiac function following this middle cerebral artery occlusion. The same procedure has done in another group of scientists to the left side middle cerebral artery occlusion as well. So there are upcoming lot of research and evidence on this animal research evidence, but we have to identify the drawbacks of these research as well, because most of these animal research studies are done in young male and healthy animals. But in our population, we usually deal with we usually have a connection. Patients come to us with disorders. So it's true that these are very important to understand the pathophysiology, but always we have to take the patient factors as well. So in the next few slides, I will explain the pathophysiology of stroke-induced heart injury. I always believe in pictures, and also I believe in a picture that if we can take from different angles, we'll have a lot of memories than one picture. So I will show you initially the three pictures, which I invite you to just keep in your mind. Right? This is one picture where I explain, and this is the other one. You can see the brain, the heart, and the central nervous system involvement, blood-brain barrier, the spleen, and the gut also. And the other picture, again, the brain is there, the heart is there. I will describe this one and this picture. So let's go back to the first picture, where the pathophysiology of stroke-induced heart injury, which results functional and structural alteration in the central autonomic network, which will cause sympathetic nervous system activation. What will happen is actually the imbalance of sympathetic and parasympathetic, rather wording sympathetic nervous system activation, and activation of the hypothalamo-pituitary adrenal axis as well, which will result in catecholamine storm as well as pro-inflammatory cytokines and cortisol secretion. This will result in neurohormonal factors as well as the factors will affect on the cardiac myocyte as well as the coronary microvasculature, which will result in electrical instability of the heart, as well as hypercontraction and reduced relaxation of the heart muscle, and metabolic and oxidative stress in the heart muscle, as well as endothelial dysfunction. So what will be the ultimate outcome? Arrhythmogenesis, contraction band necrosis, microvascular dysfunction, and coronary demand ischemia, which will present as stroke heart syndrome. So the same pathophysiology with different diagram, where the stroke, once the stroke head occurs, there's destruction in the blood-brain barrier, where a lot of pro-inflammatory cytokines will release into the bloodstream, as well as the brain, bone marrow, and the spleen axis also activate, where there are a lot of immune-mediated things happening in the bloodstream. And also there are some evidence that this gut-mediated intestinal flora imbalance also affects this brain-heart syndrome. And also there's reduction in the mRNA, mRNA 126 in the endothelium of the cardiac muscles, as well as in the bloodstream, which will result in cardiac left ventricular dysfunction and stroke-induced cardiac fibrosis. Again, I'm repeating this. So initially the stroke, it can cause inflammation because it is more like a wound, which will cause inflammation in the central autonomic network, which will cause pro-inflammatory cytokines, which will activate the hypothalamic pituitary adrenal axis, which will cause showers of norepinephrine and epinephrine. That will again affecting the spleen and the bone marrow, which will cause a lot of cytokines storm, and that will cause this pathophysiology of brain-heart syndrome. Again, the same pathophysiology, which in another diaphragm, where the activation of the pro-inflammatory cytokines, which will result in thrombosis, increased risk of thrombosis, as well as cardiac myocyte damage, and this also affects the cardiac injury. So now I described 4 pictures, but all together in a short and sweet way in this picture, where you have the stroke. The stroke characteristics are very important, where the lesion size and the stroke severity. And because of that cause the central autonomic network changes, causing the mediators. It may be immunological, it may be neurological, it may be humoral, which causing cardiac downstream mechanisms, causing impaired coronary circulation, macrophage dysfunction, and cardiomyocyte injury, resulting immediate and long-term cardiac consequences. So this is stroke heart syndrome. This is the stroke-induced heart damage. So always we have to exclude the differential diagnosis of stroke heart syndrome, which are the sepsis, CKD, acute kidney injury, and not to miss anemia also in this patient, which are easily correctable. So ladies and gentlemen, let me introduce the phenotypes of stroke heart syndrome, which is very important in patient management. Maybe acute myocardial injury, acute coronary syndrome, left ventricular systolic and diastolic dysfunction, cardiac arrhythmias, and sudden cardiac deaths. So since I mentioned the phenotypes of stroke heart syndrome, once again, I tried to put the pathophysiology and connection of the clinical phenotypes to the pathophysiological basis, so that we have patients, the patients come to us with, patients have chronic cardiac problems, and also there are acute problems. Actually, in the definition of stroke heart syndrome, yes, the patients with chronic cardiac problems, yes, we should know their baseline. Then actually we can involve them into the definition of stroke heart syndrome. So the first clinical phenotype, acute myocardial injury. Acute myocardial injury can be shown by the elevation titers of the cardiac troponin, and the higher the elevation, it causes poor cardiac outcomes. But though the guidelines says measure this, they don't say what to do after getting high titer, rising titer, what to do. So then this interesting thing is there in this paper where elevation of cardiac troponin occurs in 1 in 7 patients of acute ischemic stroke, and this is a predictor of poor functional outcome and increased mortality. And also in this troponin elevation acute ischemic stroke study, they try to find in the patients who had stroke followed by high levels of troponin and compare it with non-ST elevation myocardial infarction patients, and while doing a angiogram to see whether there are any disease vessels. What you can see is there where the patients who have stroke heart syndrome and high troponin level, nearly 20 to 24% actually had a culprit lesion. Where are we going to do cardiac angiogram in all these patients? Is a questionable and doubtful thing at the moment, and further studies are necessary for this. So since it's a very invasive procedure, how about non-invasive investigations like cardiac MRI? Yes, the sub-study of the troponin elevation in acute ischemic stroke has done the use of MRI, cardiac MRI in these patients, where they have found that might be helpful to select stroke patients who need urgent coronary angiography. So then going to the see whether these all patients with elevated troponin, whether they need some further intervention or diagnostic algorithm. Yes, this prediction of acute stroke syndrome in acute ischemic stroke, acute coronary syndrome in acute ischemic stroke study, which is still the ongoing study, we will find more answers in the near future. So going back to the second phenotype, the acute coronary syndrome. So as all of us know, there's definite criteria which the patient comes to acute coronary syndrome. But how to manage high troponin levels in stroke patients, that in a way I have tried to elaborate in this slide, where in acute stroke patient, if the stroke-induced myocardial injury is present and if it's rise more than 20%, it comes under the acute myocardial injury. If it's not, it is chronic myocardial injury, where we have to evaluate in other line. So if it's acute myocardial injury, we have to decide whether this is type 1 myocardial injury or this is type 2 myocardial injury, because stroke patients share the common risk factors of patients who have cardiac risk factors also. So having a stroke, the patient is high risk for having type 1 myocardial injury that can coexist. But the stroke heart syndrome, stroke-induced heart injury, is mainly pure neurogenic, or it may be due to a demand ischemia, due to tachycardia or high blood pressure variations. So that is the important thing we have to understand and try to find out more treatment options and how to manage these patients as a collective way. And the other important thing is the left ventricular Takotsubo syndrome, where stroke patients can present with heart failure. And also, this has shown that elevated level of troponin is constantly seen in heart failure patients. And Takotsubo syndrome, we have to specifically mention that this is secondary to stroke. And the important thing is cardiac arrhythmias, where atrial fibrillation detection after stroke is one of the evolving area in stroke heart syndrome. So we have to find whether this is a higher risk atrial fibrillation detected after stroke or lower risk detection atrial fibrillation detected after stroke. That we have need further studies. And the other phenotype is sudden cardiac death, which is defined by death occurring within 1 hour of symptom onset. So the clinical phenotypes of stroke heart syndrome is explaining this graph, where in the initial first 4 weeks, there's sudden deterioration of the cardiac function, and there's dramatical deterioration after that, where evolving studies will explain the the outcome of long-term consequences. So the clinical practice points is very important. One thing for all patients, if we can do a troponin, yes, there's a place to do a troponin. And if it's rising titer, we have to collaborate with the cardiology team. And management of myocardial infarction in stroke patients, very important. We have a lot of problems in these patients where there's one side we are worried about the bleeding risk of the infarction, bleeding risk of the and hemorrhagic transformation. Same time we have to treat with dual antiplatelets or enoxaparin. So these should be addressed. And same time, cardioprotective mechanisms like treating with beta blockers and prolonged monitoring is important in these patients. And other important thing is we have to, we can avoid giving pro-arrhythmogenic drugs as well as correcting electrolyte imbalances in these patients, and also promote or optimizing diabetes as well as sleep disorders in these patients, and help to overcome them the psychological stresses as well. So other clinical practice points, these are all evolving areas where there's no clear evidence, and these ongoing studies will give us the answers for these things. So the most important last few slides, Stroke syndrome in Sri Lankan clinical practice. Are we able to provide all recommended investigations for these patients? And we have to do a patient-centered management, and good patient communication is very important in managing this patient. So going to our CCP this year, theme holistic care amidst constraints. There are a lot of intellectual research publications coming up. Are we going to do all to our patient, or are we going to do the things that can be attributed to Sri Lanka and then selectively do to our patients? So what we have in the country, that is the most important thing. With that, maximum patient care with available resources is very important. Proper resource management, and again very important, and respecting the ethical principles. Now, some patients with stroke heart syndrome might need a coronary angiogram urgent, but we may not be able to provide. So ethical principles, we have to always have a good communication with the patient. That will heal a lot rather than going behind investigation and trying to treat patients. And also we have to safeguard the clinicians as well, because a lot of logistical issues are coming. The law always come behind, and so always when we are treating these patients, we have to try to safeguard our clinicians as well. So, ladies and gentlemen, in summary, I've tried to define the stroke heart syndrome, the manifestations of stroke heart syndrome, the clinical importance, because it has 10 to 20% of major cardiovascular risk following the next 30 days, and also the upcoming perspectives. And we need to join among ourselves, the physicians, neurologists, and all the clinicians, cardiologists have to come to a desk and discuss about this evolving field. Thank you very much.
Thank you, Dr. Deepika. We have 1.5 minutes for the questions.
Presentation as you have read by the physician, that's about stroke. I want to ask, if the early thrombolysis in stroke, would that transform into better cardiac outcome as well?
Yes, because now the basis of this stroke heart syndrome, I mentioned that the severity of the stroke. So securing the penumbra is most important thing. So we have to improve our stroke thrombolysis service, where we have to try to secure the penumbra. So then our life will be easy. Having said that, we have to have continuous monitoring of these patients because they are in risk of stroke heart syndrome.
One question now. Stroke heart syndrome, are there vulnerable group of patients except on the degree of stroke, like patients who have metabolic syndrome, who now we say this is like all due to the sympathetic activation and dysregulated immune response. So do you find that there's a specific group of patients who have
according to the given literature, sir, the age, one of the risk factors, and also diabetes, and as well as patients who have sleep disorders, they are more prone to stroke syndromes. And patients who have cardiac autonomic imbalances, also they are more prone to stroke heart syndrome.
Do you practice like beta blockers for their anti-infectives early in these patients to to predict that these patients are at risk of going into this?
So for the current medical practice and for my literature, there has been recommendations, but it's mainly the expert evidence, not level 1 or level 2. It's the expert opinion. So it's very important to have your own way of treating these patients. And also, since this is a new neurocardiology is a new evolving area, we have to always share our experience, and then we can come into a consensus on what is the best for the patient.
We come